All right, so let's jump into strokes. And we've got stroke 1 and stroke 2. There's a lot of information. This chapter is so dense. I will do my very best to provide the information I think that's most valuable, but not oversimplify it, but that's going to be a real challenge. So I think both of these, this first one has 21 abstracts. We won't go through all of them in painstaking detail, I promise you. So I'll try and summarize them as best as I can with the time that we have. And I think the next one, has 18, and it'll be equally as challenging to get through all the information. All right, so stroke guideline controversies, part 1. And really where we have to think about right now is why is there an explosion of literature in stroke? You know, there's been controversy, and we know that there's always going to be a certain number of people and a degree of discontent in all specialties, including emergency medicine, that we may not necessarily agree with IV-TPA for acute ischemic stroke. I think broadly, most of us can agree that there is safety and efficacy, but it's very difficult based on the available literature to determine which narrowly defined patient populations we can make those two statements in. It is safe and efficacious. But where we're headed now, and I think why there's an explosion of literature coming out, is just like we experienced with the treatment of STEMI. We moved away from lytics largely and went to interventional management, and that's where we're going with mechanical thrombectomy. And with some great articles that came out in 2015, now we're seeing more coming out, more questions being asked, and more literature being published to say, where should we go with this? So now we're discussing stroke again quite a bit. And also, the Heart Association and Stroke Association published new guidelines in January of last year. And what was unprecedented was they retracted them and published some corrections in April. I don't know if they didn't review them in advance, they gave them a second look, but I think they received a lot of input in certain areas. Ones I think I remember were imaging. I think there might have been something pre-hospital. And there was something definite that I think impacted us at least a little bit in blood pressure management. Sure, if you're giving TPA, they still want you to make sure that you gently lower the blood pressure to the parameters that have been previously established. But what they also said in their description was that the evidence strongly suggests, don't remember the exact wording, that patients who have an elevated blood pressure or variable blood pressures may have a higher risk of intracranial hemorrhage after IV-TPA. But they clearly state, which I don't think was stated in the previous guidelines, we don't know what that number is. So it somewhat contradicts or invalidates selecting a specific number, which is just above in the guideline, but the description says, we know this is an issue, but at what number is an issue, we have no idea. And so I think it gives you perhaps a little bit of wiggle room, but I wish they would have moved that into the guideline to say a suggestion as opposed to something that really should be done. And if you're really worried about hypertension, then perhaps it should be maybe an absolute contraindication as opposed to something to just consider. Something that's always been a question for me, which hasn't entered into the guidelines significantly, although it is touched upon and people have discussed it, is, if we're going to acutely reduce blood pressure in ischemic stroke, aren't we potentially going to expand the ischemic penumbra? So if we're going to lower the blood pressure to give a treatment to improve stroke, knowing that autoregulation is no longer in effect in that area of ischemia, we are reliant on cerebral perfusion pressure to perfuse the injured area. Now, yes, if it's wildly high, we want to be concerned about that. But in patients, particularly those who have been chronically hypertensive or there's an acute injury, blood pressure is going to go up for the purpose of perfusing the injured area. The body knows better than we do. So I would be a little cautious about just saying, well, to give a treatment, we need to lower it, if lowering the blood pressure in and of itself could be harmful. So be really cautious with doing that. So if you want to take a look at that revision, it would be interesting to look at those guidelines. Okay, so first question. What did the new guidelines say about IV TPA? And is there any noteworthy new literature? So we'll run through these quickly, but I think there are some interesting things here. So just with the guidelines, basically what they state is after CT scanning, the only other test that is needed before administering TPA is what? An assessment of blood glucose. Of all the tests that we have, blood glucose was the one. I guess it does make sense, but they've said really, we don't want you to wait for coagulation studies or platelets, and they're only necessary if you really suspect coagulopathy, which does make sense. And here's the quote. Given the extremely low risk of unsuspected abnormal platelet counts or coagulation studies in a population, IV alteplase treatment should not be delayed while waiting for hematologic or coagulation testing if there's no reason to suspect an abnormal test. Well, that's great. They want to make sure that we're not delaying administration of TPA, but I think sometimes we have found, even with getting people to the cath lab for STEMI, when we push the time limit so fast that we can't pump the brakes a little bit and decide if it's the right thing, sometimes we can make bad decisions. So we run the risk here of moving a little bit too fast. So what about abstract number 1? This is really an article talking about why people don't get TPA. So this was basically a retrospective cohort of almost 62,000 patients presenting within 2 hours of ischemic stroke. Actually, the dynamic has changed. In this registry, 75%, or 46,416, actually got TPA, 25%, so 15,282 did not. Multivariate analysis, what were the different factors for those two groups? So when you weren't going to get TPA, you were more likely to be older, non-Caucasian, you had carotid stenosis, diabetes, dyslipidemia, peripheral vascular disease, and prior stroke or TIA, and you were on antithrombotic treatment. Not saying those things should be exclusions or those should be contraindications, but this is what the group looks like who doesn't get TPA, right or wrong. So if you think that your patient may still be a candidate and you believe it's the right thing to do for your patient, then you should say, well, am I disqualifying them for some reasons that really don't make sense? Because these are some of the reasons why patients who may otherwise be qualified don't get it. All right, the next abstract I think is one of the most interesting in these two chapters, and it scares me a little bit. I'm afraid of this one. So the concept in this Greek article is whether microbleeds are important or not. So let me ask you a question. Hypothetical, but not so hypothetical. If you knew that your patient had one microbleed that you could identify by advanced imaging, would you still give TPA? Well, would you? It's a bleed in the head. It's a microbleed. Microbleeds become macrobleeds sometimes, don't they? So what do you think? Does a macrobleed worry you? Or but a microbleed, does that worry you? Okay, it should worry you. This is what's scary. So they were investigating whether microbleeds are a risk factor for significant or symptomatic intracranial hemorrhage after TPA. Systematic review of almost 2,500 patients, and they all got an MRI, which is going to be the right test to look for these microbleeds prior to TPA. And their threshold was 10 or more. Wow, so many of you said, yeah, if they have one microbleed, and I'm with you, I'm really worried at that point. So the overall intracranial hemorrhage rate was 4.9%. Any versus none, any microbleeds versus none, the ICH rate was 6.9% versus 3.2%. And if you had more than 10, the relative risk for an intracranial hemorrhage was 12.1. Wow, but their baseline standard was, we're going to tolerate this to a level of 10. Hey, once we get to 10 microbleeds, I think we're going to say this is unsafe. So I think this is somewhat biased to accepting more risk for the patient than we really should. So be aware this concept is out there, that some people are accepting a certain degree of microbleeds as an acceptable risk for the patient, where probably many of us, if we were able to do a test that showed us that there was risk for the patient and they actually had even small, micro, active bleeding in the brain, you would say, no way, I'm not giving TPA. And there are many experts out there that are saying, nope, we're going to go ahead and do it. So, yes, question? Sure. And his comment is well taken, that and I'll summarize it if you don't mind. I might be slightly more sensitive in the delivery. But basically, that there may be a bias out there in the neurosurgical and even the neurology community where there might be some clinicians out there who would say they will favor a good outcome even if it's at the risk of mortality in some cases. So they might push the envelope a bit. Okay. Yes? I'm sorry, I didn't hear. Yes, it's MRI. MRI, these are all, you've got to do it on MRI. CT won't show it. So you'd have to then go to MRI, which most of us aren't getting. And by the way, interestingly enough, in the guidelines, as we'll talk about, they're not recommending an MRI in most cases. But I think we have a disconnect in how we understand this disease and what's safe and what isn't safe. Because if we know this, if we believe this article is true, and a lot of patients who actually have microbleeds are going to get TPA, isn't that something we should know on everybody? Perhaps it is, and we need to think about it. And so just a thought for you. Yes? Yeah. He brings up a good point. He brings up a good point. And you mean down here by like in the valley out of the mountains? Because we're in Arizona. Or you mean, because you're from Canada, right? So you mean in the southern hemisphere down here in the United States. I gotcha. Yeah, well, I think it's variable. We have variable access to MRI and to those protocols to assess this. And I imagine, just like we have found with other imaging studies, there's going to be variable interpretation accuracy until people get better at looking for these types of things. So, yeah, we're not going to be able to find this in everybody. But I would say the places who are likely to be doing a lot of these type of treatments need to be thinking about this and factoring this in on the front end. And based on this article, it sounds like we probably are not. And if we are, there are some people who are really allowing a significant amount of risk with this that maybe not the rest of us who might be administering or ordering TPA would be comfortable with. And I think, based on the level of discussion here, you found it to be an interesting article too, but I was surprised by this concept. All right, let's keep moving on if that's okay, and I'll be around later to talk more about some of these concepts if you'd like to. All right, so the next one, cost of TPA. So this is a quick one, but the cost of TPA has increased 111% from 2005 to 2014. 100 milligram vial, $2,867 in 2005 without a coupon versus $6,153 in 2014. And by the way, the CMS reimbursement only increased by 8%. So the cost is significant for this, and it's escalating. And recovery of that cost on the hospital side isn't happening. All right, abstract number 4. So this is a review article about where we are on this debate. And again, I don't intend to open up the debate today, but there is still significant controversy and non-acceptance of TPA in ischemic stroke being the only standard or being the standard of care. It is one standard, and it can be applied in appropriate patients, but it may not be the only standard to use. So this was published in October 2016, and it's not much different than what you have heard from others who are very skeptical about TPA. So basically, systematic review, 26 randomized clinical trials, 10,431 patients that compared the effects of IV TPA and other agents in patients with presumed acute ischemic stroke compared to placebo or standard care. So I'll just cut to the chase on the results, and this hasn't changed recently because there hasn't been much new evidence that's come out recently. Only two studies showed a favorable and significant treatment effect with IV thrombolysis, and most of them being TPA, but with significant baseline imbalance. So one group may not have looked the same as the other group, etc. So they're not perfect studies, but only 2 showed benefit. 5 of the earlier studies, if you recall, were stopped early due to harm or lack of benefit. So that we have to remember that that's in our history. That's why I'm kind of excited to see this move to an interventional approach, because where TPA for MI worked really well, I think the efficacy and safety is much more demonstrated in that disease process than in the fragile ischemic brain. So this article, I won't speak about it in much more detail except to say that they looked at it, and yes, you might think based on that first statement that these people might have been biased to say that they don't believe TPA is effective. But they actually said that they really thought it was effective. The overall findings were that fibrinolytic therapy in acute ischemic stroke does increase intracranial hemorrhage and early mortality, but it also improved functional outcome. So here's some of the individual data on that. The overall benefit, the odds ratio for benefit when you looked at this pooled analysis was 1.14. So there was benefit. But if you looked at, again, you looked at the risk for all of these agents, early mortality, 1.51. So that's a concern for us. So there is significant downside risk for doing this. But the authors are good to note that when they looked at the evidence, they can see some upside benefit. But we're really going to have a very, very good informed discussion with our patients regarding whether this is a good decision for them. But it's not what many people have professed it to be, that it's an absolute, this is the only thing to do, there's no other option, and why wouldn't you do this? There's some very good reasons why you would not, and I think you have to include some patient discussion in this. All right, the next question. What about Tenecta Place versus Alta Place? And just a quick article on this. Was it really better or was it not? Was it equivalent? This basically said that it wasn't superior. This is an intention to treat analysis, which is important. If you randomize people into your trial, What you want to know, what all of us want to know, is not the people that followed the protocol perfectly, but everybody that you would have treated. Just like when we work, everything isn't perfect. When someone comes into the emergency department, everybody's intention to treat. And we want to know what happens in a practical sense. So this was intention to treat only. Excellent functional outcomes at 3 months, 64% versus 63%. 3-month mortality, it was equivalent at 5%. So really, it wasn't better, wasn't worse. So if you wanted to use this other agent, and that's what you had available, you could probably do it without much concern. The next question. Mechanical thrombectomy has gained a lot of momentum over the last 3 years. What does the most recent literature say? And it really says that there is a lot of momentum going this way. There is efficacy, there is safety, but I will tell you the reason for that also is there is a very, very limited, narrow number of people who would be screened for this and who would be eligible, and that's the way the trials were established too. So what I'm concerned about is indication creep. I think the studies have been fairly well done, most of them, and the data is pretty credible. But if we expand this to everybody instantly, by the way, we don't have the resources to do it everywhere. And also, are we going to have the same results with broadening this to multiple patients? I don't think so. And if you look at what some of the earlier studies said, they were considering anterior circulation. They were also considering posterior circulation, all the arteries. And now it's kind of backed off to anterior circulation, proximal. Proximal anterior circulation, most of the time it's going to be the internal carotid itself or the first branch off of that internal carotid, which is the first branch of the middle cerebral artery. That's basically largely where the greatest benefit is seen. When I hear people saying, well, we think it can work for all large vessels, let's do it in the basilar artery, absolutely not. There is no evidence to support thrombolytics in posterior circulation stroke or mechanical thrombectomy in posterior circulation stroke. So be a little bit careful that we don't get indication creep. All right, so abstract number 6. This is a meta-analysis, 8 randomized trials including 2,423 patients, large vessel occlusion, which is what we're looking at, and they use, just as I stated, the internal carotid or the middle cerebral artery. Functional independence at 90 days, 44.6% versus 31.8%. Number needed to treat was 8. So, I mean, this is pretty compelling that this works for the right people. And what's fascinating, the earlier studies, they selected the sickest of the sick. They already got TPA. They took them in, and then they had a lot of bleeds and bad outcomes. What we're finding with all of these studies is there's no difference in intracranial hemorrhage. So, I mean, that's fascinating and helpful. And so I think when you look at that factor, the concern for increasing intracranial hemorrhages is much of a less concern than it was with some of those earlier studies when we were taking those sicker patients. But that also created some issues with the literature, because oftentimes in the earlier studies this was used as a rescue treatment. So everybody got TPA and then they got mechanical thrombectomy. I wish we went back in time several years ago and said, before we ever do this, let's just go head to head with the two treatments, mechanical thrombectomy and IV thrombolysis. Now, we have some data in this chapter that suggests that that's been looked at well enough now, but I will tell you, starting in that way would have been nice. So, abstract number 7, time to treatment. Basically, this does show that there are some concerns about time to treatment and where we should do this. So I'll summarize it quickly. So 70% of the cases in this article were the M1 branch of that middle cerebral artery, which is where it's the bifurcation of the internal carotid. So that's proximal, large vessel occlusion, anterior circulation, really, really important. The median time to randomization was 196 minutes. A longer time to mechanical intervention was associated with increasing disability, including a decrease of 4% in the odds of a favorable outcome for every additional hour of delay after or until reperfusion. So it was important. And so until approximately 7.3 hours from symptom onset, at which point a statistical benefit of mechanical thrombectomy was no longer apparent. So they're saying at about 7 hours, they were saying, after that point, we're not going to really benefit too many people. So it's important to recognize, based on this abstract and others, that there are time limits to this, although many others have tried to push us out even to 24 hours. And maybe in some cases that might be appropriate. But we have to base our treatment decisions on the literature and not what we would like to be efficacious. So abstract number 8 really looks at an interesting concept here. So determining the number of ischemic strokes potentially eligible for endovascular thrombectomy. And I commented on it earlier, and we have to be really careful not to apply this to the wrong people. This is really not going to impact a bunch of people at this point. So in quick summary, what they did was they took a look at former stroke patients and they said, all right, if we had a really restrictive protocol or algorithm versus a fairly liberal algorithm, what does that look like? With the restrictive algorithm, 7% would have been eligible. With the more liberal algorithm, 13% would have been eligible. And so even if with the most liberal algorithm, which is beyond where we would go today, only 13%, keep that in your mind, that 13% of your patients are going to be eligible, and you're going to be pushed, I think, in the near future to drip and ship a lot of patients for potential mechanical thrombectomy when it may not be indicated. All right, so abstract number 9, safety and efficacy of thrombectomy in acute ischemic stroke, 1-year follow-up. So this is important because this is the first study that actually looked at outcomes beyond 90 days. Small study, 206 patients at 4 stroke centers in Spain. So 1 year, and with mechanical thrombectomy, the adjusted odds ratio was 1.8 for overall improvement in the modified Rankin scale score. So that's important to note that they found benefit all the way out to 1 year. Functional independence at that 1 year was 44% versus 30%. Mortality was fairly equivalent, 23% versus 24%. But the outcomes were better all the way out to 1 year. Abstract number 10, this is about different devices, and I don't think there's a lot to say here, except that we think maybe some of the improvement in the literature may be because the devices could be improving also. In this particular article, the Solitaire device was used in 97%, 984 patients with large vessel occlusion within 8 hours, symptomatic intracranial hemorrhage rate, 1.4% overall, and compared to recent randomized controlled trials, they had similar good functional outcomes at 56.5% versus 54%. Excellent outcomes from registry data, 43.2% versus 35.8%. So this, of course, was comparing some devices, but this does speak to still to the question of whether we think there's efficacy and safety here, and it appears that there is. But we have to be cautious. The next question, how are patients identified as potential candidates for thrombectomy, and what about timing? So basically, the 2018 guidelines are telling us to do this, and I'll read this off to you. So number 1, the pre-stroke modified Rankin scale score should be of 0 to 1. Number 2, causative occlusion of the internal carotid or MCA segment 1. So the guideline says segment 1. Others are going to say, I think we might be able to get to segment 2 or 3. And certainly the guideline isn't saying anything about posterior circulation, so be careful. Number 3, you've got to be 18 years or older. Your NIH stroke scale score needs to be 6 or greater. Your aspect score needs to be 6 or greater. That's when you look at the CT and look for signs of ischemia and graded. It's a 10-point scale. And 6, treatment can be initiated so you can have the needle in within 6 hours of symptom onset, and that's a class 1 recommendation. So the guideline says 6 hours. The guideline says specific vessels. So we have to make sure we stick to that guideline. So Abstract 11 speaks to this as well. They actually tried to expand this a bit to the M2 distribution. They looked at only M2 distribution, 522 patients within 8 hours of symptom onset, independence at 90 days, 62.8% with mechanical thrombectomy versus 35.4% with medical treatment only, an odds ratio of 3.1. So they said, you could do this with the M2 distribution. But remember, the guideline doesn't say we should do that at this point. And again, speaking of the concept of indication creep, here is a direct quote from the guideline as well. Although the benefits are uncertain, it may be reasonable to consider thrombectomy for patients with causative occlusion of the anterior cerebral arteries. That's not just anterior circulation, it's anterior cerebral arteries. That's a different set of arteries, vertebral arteries, basilar artery, or posterior cerebral arteries. That's a class 2B level C recommendation. So again, not good evidence why are you even stating that in the guideline when the primary recommendation is really just the internal carotid or the M1 distribution. Don't muddy the water, but they have to a certain degree. Now, the next two have really, I think, changed things quite a bit. 12 and 13, Dawn and Diffuse 3, So Dawn, November 11, 2017, they basically looked at going all the way from 6 to 24 hours, and they really wanted to identify, and I love this concept, a mismatch between clinical deficit and the infarct. So basically, these two studies say, if you've infarcted, do we have any brain tissue that has a vascular distribution that we can save? And if we can't, based on advanced imaging, then why are we doing this stuff? This is a good move forward, I think. But these also run the risk of indication creep and expanding time frame. So just giving you a little bit of sense of this, they looked at internal carotid or proximal MCA. Median time was 12 to 13 hours. 206 patients, 107 had endovascular treatment, so mechanical thrombectomy. Functional outcome at 90 days was 49% in the thrombectomy group compared to 13% in the control group. So pretty impressive there, but this was also sponsored by Stryker, so there was industry sponsorship, just be aware of that. And Abstract 13, Diffuse 3, February 22nd, 2018, they also were very bullish on the concept. They said go out to 6 to 16 hours, and here was their quote in their conclusion. Endovascular thrombectomy for ischemic stroke, 6 to 16 hours after a patient was last known to be well, plus standard medical therapy, resulted in better functional outcomes than standard medical therapy alone among patients with proximal middle cerebral artery or internal carotid occlusion and a region of tissue that was ischemic but not yet infarcted. That's where the new evidence is going, where the new technology is going. So I like this, and I think they did a pretty good job with it. 182 patients, small sample again, functional outcome at 90 days with a modified Rankin scale score of 0 to 2, 45% versus 17%, with a p-value of less than 0.001. Let me just make one quick comment here, but I think there's a misconception, huge misconceptions about how to generate and apply p-values, and this came to mind as I was looking at this chapter, and I'll share it with you. When you've met your p-value that you've set, and the general number out there is less than 0.05, you might establish it differently for your study. But if you exceed that, or it's a really, really, really tiny p-value, that does not imply greater statistical significance. It just means you met the barrier that you set for yourself for statistical significance. So don't look at it and say, wow, it must be really, really a good study, or this must really, really work better because the p-value was so good. No, it's a yes or a no answer based on what was established. So just be careful with that misconception. 90-day mortality, 14% versus 26%, but the principal investigator had financial ties to this, I believe this company or this product called IschemaView, which is the software they used to look at the perfusion deficit mismatch. So I think the technology makes sense, but again, there is some industry potential for bias here. All right, the next question, what is the number needed to treat for thrombectomy and stroke based on 14 systematic review and meta-analysis? Only grade 1 studies, when they were only grade 1, 12 studies were looked at. High quality evidence, number needed to treat was calculated at 38. If you took the crappy studies along with it, the not so good studies, number needed to treat went to 8. So we have to be careful that we're looking at good quality evidence, but it does appear that even a number needed to treat for 38 in the right patients, knowing that it's probably at best only going to impact 13% of our stroke patients, then this may make sense. But we're really running the risk of indication creep and other downstream complications we have not considered. So biggest part of our chapter I'll summarize quickly. So the question is, do patients undergoing thrombectomy also receive IV thrombolysis? Yes, they do. Are there studies directly comparing mechanical thrombectomy to IV thrombolysis? 15 to 21 are these abstracts. We're not going to go through all of them. There are some that did compare it. It's limited. There are others that were able to compare a significant amount of data about whether it's safe with doing what's called bridging therapy, using the IV lytic and then transporting someone and going ahead and doing mechanical thrombectomy, or doing it at the interventional or stroke site and giving the lytics. The standard at this point is not to use mechanical thrombectomy alone. Based on all these abstracts, and you can certainly make your own determination about whether you believe this evidence to be significant enough and supportive enough to formulate a final conclusion. But the overall conclusion of these final abstracts are that the combination is just as safe as mechanical thrombectomy alone. The outcomes are better, and you absolutely can do this. And so that's the overall summary of 15 to 21. I won't take you through the painful journey of reviewing every single one of those abstracts, particularly since we're at our time. Yes, question? I think so. Her question, as Jim comes up, and I think it's an important topic, and I'll hit it quickly. I'll try to. So she said that their system, their whole hospital system, has gone away from getting consent for TPA. So here it is. There is a standard of care for obtaining consent so that patients understand the risks and benefits of their treatment. Is the administration of TPA and stroke a complex topic? Yes. It is. So can we expect that a patient will understand the risks and benefits? No. So there is a legal standard that they must be consented. Now, the people who say we don't need to do this because it is the standard of care, well, first of all, that has nothing to do necessarily with consent. But even if it were the standard of care, here's the discussion point I will say that you can share with them. So patients come into most emergency departments with an acute appendicitis. How do they get that treated? What's the overwhelming standard of care? Has been for a long time. They go to surgery. So at your institution, apparently they must not get consent for the operative consent for appendectomy, or they must not get the consent from anesthesiology because appendectomy is the standard of care. That's the discussion I'd like you to have gently and sensitively with the people at your institution, because there is a legal standard that allows patients to make decisions, and we should not be making complex decisions for them. Thanks. And Jim, thanks for letting me address that question.